and also nurses and physician extenders in the emergency room also found the system useful. So what data did those users tell us would be of most value? Well, the following list we developed over a series of meetings with numerous physicians and stakeholders across the organization. And they are fairly obvious, but at the same time it was a very useful exercise, and we did identify a few things that would be valuable that we hadn't expected at the outset. So what we have listed here is the problem list, medication list, allergies, demographics, especially one thing we didn't necessarily expect at the outset that would be useful in demographics, but turned out to be very useful, is just having the patient's contact information, who to contact other than the patient in the event of various issues. Encounters also turned out to be extremely useful to find out who the patient's providers were, such as specialists like cardiologists and primary care physician and so on. Laboratory results seem fairly straightforward, but again, the integration of the commercial laboratory results turned out to be particularly important. Immunizations, and what turned out to be really important that we even if we had it to do over again, would have put at the top of the list and implemented first as clinical documents. So then we had to figure out how to deliver this integrated information, and the ideal way is in their workflow, in their EMR. However, in the with the goal of delivering early value, it's just not possible initially to collect the data from all the various sources and then push it to other places where it doesn't currently exist. So to take the allergy from Cerner and push it to Cerner, or to take the allergy from Cerner and to push it to Epic or vice versa, was enough of a technical hurdle that it wasn't something we could do right away. So what we did was we implemented a web-based viewer that provided a view into the integrated information, and we built that viewer as much into the workflow as possible, and I'll also illustrate that as I go through. And again, the semantics, and I'll show you examples later, but that allowed us to trend laboratory results from multiple different laboratories and multiple different organizations over time, and the semantics also helped us to reduce information overload in that web-based viewer. And again, the data exchange, the reason for not doing it right away was it's just too high a technical hurdle to leap in the early phases, but we've since conducted a pilot project of data exchange, but that's another topic for another webinar. So our first phase, in the first 10 months, we were able to implement and pull together problem list, medication, and allergy data from 4 electronic medical records. And again, those 4 electronic medical records have since condensed to 3 electronic medical records, but we still actively obtain those data from those 3 electronic medical records. We're getting laboratory results from 12 or more hospital laboratories at this point and 1 commercial laboratory. We're getting encounter information from 12 hospitals and over 200 outpatient sites. And demographics data similarly from the 2 registration or admission, discharge, and transfer systems that manage the 12 hospitals and 200 outpatient sites. And I think that's actually an underestimate, because we have we also pulled in registration ADT data for encounters and demographics from a number of other hospitals that weren't included. So it's more like 15 or 16 hospitals that we have encounters and demographics for. And we also did a history load of all those types of data into the DB Motion clinical data repository for each data source. So with encounter data alone, we went back 5 to 10 years depending on the source system. Laboratory data went back at least 2 years, and we got all active problems, medications, and allergies from all 4 EMRs back as long as the EMRs were implemented, which for some sites was as old as 8 to 10 years. And then our phase 1 rollout, we rolled out to several dozen pilot users, including the ED physicians I mentioned previously, our group of physician IT champions, which included myself, and the outpatient practices, and including also some physician extenders, a nurse practitioner and a physician assistant in the ED as well. And again, we implemented DB Motion's clinical data repository and brought all the data together in one place there, and we used the DB Motion viewer. And to make it as close as possible to the physician's workflow, we enabled a one-click launch from the electronic medical record the physician is working in Cerner and Epic. And we maintain the user and patient context, so as soon as they clicked with the one-button click in Cerner, they were then at the summary screen in DB Motion. And we also did a pilot of the semantics, and we implemented a number of vocabulary translations, and I'll show you what those look like and what effect they have for the users over the next few slides. The second phase took another 18 months after that, and we brought in the other high-value data that we identified, especially the notes and the discharge summaries and the progress notes and the consult reports and the operative reports and pathology reports. Our end users thought were highly valuable, so that's why those are in italics. We also brought in immunizations from two of the three electronic medical records and microbiology data. Before we went live with those additional data types, though, by the time we went live with those data types, we had already rolled out to over 1,000 users, in the neighborhood of 1,500 to 2,000 users, and I just can't remember the exact numbers and where we were, but certainly by the time we had that data live, we had 1,500 to 2,000 users of the system. And we had discovered that the system had utility for radiology department staff, operating room staff, and physician extenders. And the radiology department staff found it most useful for looking for allergies to radio contrast media, as you might imagine, and also for trending patients' renal function or kidney function over time through the laboratory results of blood urea nitrogen and creatinine test results. They were also concerned about nephrotoxic or medications that are toxic to the kidney, such as various intravenous antibiotics and chemotherapy and so forth. The operating room staff found it helpful in the context of clearing patients preoperatively, because a lot of times patients who come to the core central academic hospitals in downtown and Oakland sections of Pittsburgh have their preoperative work done at the community hospital. So just being able to get the community hospital laboratory results and radiology results to them in a time-efficient way in a single location improved our ability. It reduced the amount of time it takes them to collate all that data and have patients clear for surgery, which hopefully leads to less operating room cancellations. So we went through a number of iterations of demonstrating the value of the system to upper management to sustain the interoperability program. So our initial attempt was to collect a series of case vignettes along the lines of, because I had access to DB Motion, I saved this patient's life. And that was the general approach to those case vignettes. And we collected several dozen of those, and they were fairly helpful in that regard. Also, I mentioned some of the effort, the work we did in reducing the effort to collect data to show that the patients are safe to go ahead and take to the operating room. And we had some numbers around that, and unfortunately, since I've left UPMC, I don't have those numbers with me, but it was substantial reduction in the amount of time, some on the order of greater than 40 to 50%. And also to demonstrate value, we went through a number of iterations of developing usage statistics of the system. Although as our effort matured, we realized that raw numbers weren't as important as we just want people to look at the data when it's critical that they look at the data. So here's an example of one of the case vignettes.